Allergy and Asthma Network welcomes you to our 2017 webinar series titled Advances in Allergy and Asthma. Our webinars are also brought to you by the American College of Allergy, Asthma, and Immunology. This is Sally Schessler, Director of Education for the network. This webinar series helps Allergy and Asthma Network live out our mission to end the needless death and suffering due to asthma, allergies, and related conditions through outreach, education, advocacy, and research. The goal of our series is to share guidelines-based information and resources with you that contribute to your life and your practice. We are joined today by Dr. Stephen Tillis to talk with us about taking a pulse of asthma in a 15-minute office visit. Dr. Tillis is clinical professor at the University of Washington, executive director of Asthma Incorporated Clinical Research Center, and physician partner at the Northwest Asthma and Allergy Center. He received his medical degree in 1990 from the University of California at San Diego after earning a BA at Harvard in 1982. He completed his internship and residency in internal medicine at the Oregon Health Sciences University in 1993 and his Allergy and Immunology Fellowship at the National Jewish Center for Immunology and Respiratory Medicine in Denver in 1995. Before moving to Seattle in 2000, Dr. Tillis spent 5 years as Assistant Professor of Medicine and Pediatrics and Director of the Allergy and Asthma Clinic at Oregon Health Sciences University. He is board certified in both internal medicine and allergy and immunology. Dr. Tillis splits his time between seeing patients in clinic and working at Asthma Incorporated Clinical Research Center, a nonprofit clinical research center in Seattle. He has served as principal investigator for more than 140 clinical trials, evaluating treatments for asthma, rhinitis, urticaria, and food allergies. Dr. Tillis has been selected on the lists of Seattle's Best Doctors, Seattle's Super Doctors, Washington's Best Doctors, and America's Best Doctors. Dr. Tillis is a past president of the Western Society of Asthma, Allergy, and Immunology and the Oregon Society of Allergy, Asthma, and Immunology. He is currently president of the American College of Allergy, Asthma, and Immunology and serves as a board member of the American Board of Allergy and Immunology. Thank you so much for being with us today, Dr. Tillis. We're eager to hear about managing the 15-minute office visit.
Well, thank you very much, Sally, and welcome everyone. I'm hoping by the end of this session to share with you my approach to sort of quickly obtaining and analyzing information from a patient who comes to an office. As you know, there's increased demands on our time, and it's kind of a tall order when the patient has asthma. As an outline, we'll first talk a bit about some relevant background, and then we'll dive right into the actual patient visit components, leaving out treatment, of course, because we're just taking a pulse of asthma at this point. Start with a history, then physical exam, and then finally any office testing that might be accomplished in that time frame. This may be already well known to this audience, but in case you don't know it, asthma is still a major problem. The lifetime asthma diagnosis among people in the U.S. now include about 39 million and 10 million children who've had asthma at some time in their life. And of those current asthmatics, there's almost 19 million adults and over 7 million children. Between 2001 and 2011, asthma increased in the United States by 28%, which is a significant rise and has not stopped. Also in 2008, among children between age 5 and 17 who have one or more asthma attacks in the previous year, they missed a combined 10.5 million days of school. Similarly, among adults who were employed and had at least one asthma attack in the previous year, there were 14.2 million days of work missed due to their asthma. And finally, in 2010, there were more than 3,000 deaths, more than 400,000 hospitalizations, and nearly 2 million emergency visits for asthma, and 14 million physician office visits. So hopefully you will agree with the CDC and myself that asthma still remains a major problem, despite all of the wonderful treatments and guidelines that have come out in the last 20 years. So let's jump right into what's important these days. Well, we always knew symptom control was important. But now in the last few years, we've added future risk of adverse outcomes and have tried to quantify that objectively based on studies that correlate, that make observations that correlate with adverse outcomes in the future. And some of those things include beta agonist use. For example, albuterol being used regularly is a significant risk factor, and I use it as a separate problem on the patient's problem list. You may be aware of data that's now 20 plus years old that using a patient that comes in saying they have used 2 or more canisters of albuterol in the previous month are at much higher risk of dying from asthma, and that is an independent risk factor. But even with less consumption than that, it's a big problem. Low FEV1, which is the main criterion we use from spirometry, is a risk factor. We'll talk more about that. Allergens and smoking and other exposures are important, as well as comorbidities such as obesity, sinusitis, food allergy, and other allergies. And then in particular, prior asthma exacerbations, ever having required artificial means of respiratory support such as intubation or requiring a corticosteroid in the past year. So these are all important risk factors for doing poorly in the future, regardless of whether there are symptoms today. In terms of goals of asthma management, of course, we want good symptom control. In the past, say, 15 years or so, we've established normal activity levels, including exercise, as a goal that is basically a right of all asthmatics to want to achieve. A minimal risk of exacerbations and irreversible airflow obstruction. So that is spirometry that's abnormal and permanently so, which happens over time with asthma. We also would like to avoid treatment side effects. So this is a balance of our over-aggressive treatment at times as potential side effects. And analogous to that, and a very important goal, is to make sure that the patient and their family are satisfied. And that sometimes is at odds with the way we were trained to manage asthma. But it is very much in tune with our precision medicine mandate. And I think all asthma specialists are acknowledging that now. Let's move on to history. You've got 15 minutes before the patient is out the door. So we'd like to be able to obtain a history in somewhat less time than that, so there's some time to discuss management and other things. What I call quick and dirty new patient questions, that is, patients I would ask somebody that I've not seen before who is there for asthma. Have they been hospitalized overnight? Have they ever been intubated because of asthma? Have they ever required an ER visit for asthma? And have they ever required oral corticosteroid treatment? If the answer is no, and that's about a 10-second surefire test, it's like the details we don't necessarily need to go into in every visit because there's not time for every single occurrence in a severe asthmatic. But those are good screening questions for new patients. But what other questions are important to ask? Well, in the past 6 months, have there been flares? What medicines do they take regularly? Whether medicines on their medication list? And hopefully you will have this as a provider on the medication list as the patients are being checked into the room. So we get to cheat in that respect. But I would also ask them what else they have on hand. For example, daily medicines, frequency of symptoms and need for albuterol use, specifically whether they wake up at night from asthma. And it's important to distinguish difficulty breathing that happens every time they lay flat from difficulty breathing that happens after being sound asleep for 5 hours and 4 o'clock in the morning waking up, pulling the albuterol off their bedstand and relieving the symptom. Then, of course, a screening for any new triggers in recent weeks to months and new exposures. What about those comorbid issues we were talking about? So rhinitis and or sinusitis are almost ubiquitous among asthma patients. At least rhinitis is well over 95% of patients with asthma have rhinitis. Asthma is just in some ways a subgroup of patients with rhinitis. So, and there is actually immunologic crosstalk between the nose and the lungs, and and the sinus and the lungs. So, failing to control nasal symptoms and nasal inflammation often will interfere with response to asthma management. Acid reflux or gastroesophageal reflux disease is a significant comorbidity. In recent years, we're less impressed by how reflux causes asthma or increases asthmatic inflammation, but it absolutely causes symptoms that are subjectively worse from asthma than there would be without reflux. And so that's a problem that's important to acknowledge and screen for. Obesity, there's a whole new literature on obesity and its detrimental effect on both the chance of developing asthma and the symptoms of asthma itself. Anxiety is a common comorbid condition with asthma, as it is with our society in general anyway. But I think it's important to realize that many patients with anxiety perceive dyspnea quite differently than had they not had anxiety. And then, of course, pregnancy. Well, how do we define asthma control? There may be some debate about this, but certainly they can't have symptoms more than twice a week and be considered to be completely controlled. Many of us like to have patients have symptoms less than once a week. Are they having nocturnal asthma? Are they requiring a bronchodilator more than twice a week for their symptoms? And are activities limited by asthma? And these are all often captured within specific validated questionnaires, which we'll talk about in a minute. Let's move on to physical exam. Remember, we only have 15 minutes with this patient. And this one's probably the least comprehensive of the elements of required to do a pulse of asthma. For example, the physical exam may be completely normal, and they could have completely out of control moderate to severe asthma. So it's an interesting dichotomy, or often if there is an abnormal finding, it's limited to nasal turbinate edema, which is inside the nose and reflects inflammation due to rhinitis, not due to asthma directly. However, things like hyperinflation and, of course, auscultating wheezes or crackles on exam are important findings. But quite frankly, active wheezing is rarely a surprise by the time I get to the physical exam. So you can usually tell by other means, but not always. And so it's therefore important to perform the exam. And how about office testing? This is of critical importance, and I think we advertise this webinar as something that is going to be discussing spirometry in a little bit of detail. And spirometry is actually an essential component of asthma assessment. It is not a one-time assessment. It's something that should be measured periodically over time. And it's like many tests, only as good as the technique used and the quality of the testing itself. There are technical issues that can be evidenced by examining flow volume loop, which we'll refer to in a minute. Reproducibility of individual efforts. There are extensive criteria that are available for technique of spirometry from the American Thoracic Society, and that can be obtained free of charge online. And there are ATS criteria that many of our office spirometers will analyze automatically and tell you whether that effort met the criteria. And then, of course, who the technician is critical. At a pulmonary function laboratory in a hospital, there'll be people that do this for a living, and they're much more likely to have thorough, not just thorough training, but such repetition that they're going to be extremely reliable. In our clinic setting, and especially in allergy asthma practices, where our standard is to be able to do spirometry with office visits for any asthmatic, on demand, basically. That the training and coaching of that technician is critical, and so we try to do in-services at our practice frequently, because it could be often a medical assistant who's also the one that's going to do skin testing or a vaccine, for example, and so they have many hats they wear, and so training and retraining and observation is critical. Well, what about flow volume loops? Well, let's analyze this one, and hopefully you can see my little arrow here, though there may be a little bit of lag. The flow volume loop, many of you may be familiar with this already, but in the y-axis is the velocity of air, or the flow of air, expressed in liters per second, and the positive direction is exhalation, and a negative direction is inhalation. At the start of the effort, when you have the patient take a deep breath, as deep as they possibly can, and blow out forcefully into the mouthpiece, you'll see that the velocity of air goes way up right away, and then is sort of sharply comes down. And on the x-axis is volume. So there is actually not a time component on this flow volume loop. It's just flow and volume. So in this case, the volume from taking a deep breath and blowing out hard until there's no more air coming out. So when flow reaches zero, in this case, it's about 5 liters, which is what these numbers on the x-axis are. So, and then on the inhalation, at the end of that exhalation effort, you take a very fast, deep breath in through the mouthpiece, and it looks like half of like a basketball, a semicircle. Whereas in the exhalation, it's more of a very deep mountainside. And that difference in shape is due to the difference between the mechanics of the lungs and the air laminar flow through the glottic opening near the vocal cord. So the upper airway is more in control of the inhalation, whereas the lower airway is going to be reflected with the exhalation. So that's a normal flow volume loop. And I always look at that to make sure it seems to make sense to me before I look at the numbers. One of the other things to look at is how many efforts were done. In this case, there were 3, because you can see slight variation here. And are they superimposable on the exhalation? And in this case, the answer is yes. So these look like really good efforts by a really good technician. And the numbers you see, the forced expiratory volume in 1 second, it's 4.3 liters. This was measured by the computer in the spirometer. So 4.3 is right out here. So that means that all this air from this 0 all the way up here was all in the first second, okay? And then the rest of the time, it's just right there. So the forced vital capacity, which is this number, the 5 way out here, is almost just a little bit more than the FEV1. So we have 100% FEV1, 108% FVC. That ratio is high. It's almost 0.9. The FEF 25, 75, I'm not going to talk a lot about, but that's the forced expiratory flow in the sort of 25% into it to 75% into it. And it depends where you trained, whether you focus on this and whether you think it has significant meaning. I trained in Denver, as Sally mentioned, and I was trained to totally ignore this. So since moving to Seattle 17 years ago, I've stopped ignoring it just so I don't offend some of my colleagues that really believe strongly in it. But it's basically in some ways analogous to FEV1, but it's much more volatile. So it's going to be more sensitive, and so in mild obstruction, it's going to be a more pronounced abnormality. But you can also see that in pretty normal patients as well. So I think if people like this, they can use it, but if you don't, you don't have to. And then finally, this ratio FEF 50 to FIF 50. So this is forced expiratory flow at 50% of FVC. Remember, FVC is up here at 5 liters, forced vital capacity. If you take half of that, you're at 2.5 liters. And the expiratory flow at that is about, 5 liters per second. And then the ratio of that over the inspiratory flow, which is down here, sort of like 6, so 5, 6, in this case, 0.8. So that's normal. Anything less than 1 is normal. Actually, anything less than 2 or so is probably not worth commenting about in most cases. So those are kind of a quick and dirty that once you're experienced with interpretation, this is the brain sort of understands this and can digest it in literally 2 seconds. All right, so that's normal. Let's move on to reversible intrathoracic airflow obstruction, which is also known as asthma. This is basically diagnostic for asthma. If you get that, notice on the exhalation, there's this fast upswing, just like it would have been with a normal. But instead of a steep mountain that comes down like this, it's what I call the south side of Mount Hood, which is you can kind of walk up without using having to use technical equipment, for example, if you're mountain climbing. It's a much more gradual slope here. And then after using albuterol, for example, 15 minutes later, you redo it, and it's a little steeper, and the area under it is clearly bigger. In this case, there's a little bit of a technical thing because you get this nice semicircle with inhalation, but they didn't get all the way back to zero for whatever reason. So normally these would connect, but I would say there's clearly nothing wrong with their inhalation. And when you look at the numbers, you get it's a different patient, different scale, but this 16% increase is reflected with these curves. The FEV1 to FVC ratio, which is kind of like the slope of this downslope, is much less than it was in the normal, and improved somewhat with bronchodilator. And again, both the inhalation ratios are normal. Well, let's do one final pattern that's important to recognize and is on I've had on board exams many times, which is variable extrathoracic airflow obstruction. And so extrathoracic means it's outside of the chest. So in this case, in our specialty, we're primarily talking about the larynx, which is just closer to the mouth from the vocal cords or from the glottis, which is where the air goes into the chest. And normal exhalation, multiple efforts, but on inhalation, there's almost very little velocity of air here. So even though this isn't a time thing, in this case, this exhalation might take, 2 seconds or something, and then the inhalation might take 5 or 6 or 7 seconds because they're kind of just gradually getting air back in. And so that's a classic curve for extrathoracic obstruction. Normal FEV1, normal FVC, normal ratio, even normal or even hypernormal FES 2575, but a markedly increased ratio of forced expiratory flow at 50% over forced inspiratory flow. So that's the classic inspiratory truncation that you hear people talk about. So this is all three of them, so you can see visually side by side and the differences in the number. And I won't, in the interest of time, review those again individually. Well, I also mentioned testing. Beyond spirometry, there's other kinds of tests that have become really important. And the first is that I'll review is called the asthma control test. And many of you may be familiar with this already. There's on this test 7 different items that measure, 5 different items that measure recall from the patient over the previous month. Each of those items is rated on a scale of 1 to 5. So you can get a maximum score of 5 times 5, which is 25. So 25 would be perfect. And technically in the validation, anything over 1 is, anything over 20 is defined as well controlled. And this has probably become the standard in daily practice for documenting asthma control with a questionnaire. There's also a asthma control questionnaire, which is analogous in some ways. In this case, there are 7 items, 6 that are based on recall, and then 1 where you plug in the FEV1 at the end. And it is based, the recall items are based on a 1-week retrospective evaluation. And the higher the number, the worse controller is. So it's different than the ACT. And greater than 1.5 is poorly controlled. So you want a really low number with the ACQ. Most of us don't use that, although it's certainly reasonable. And many of the clinical studies we've been involved in use that index. And then finally, we have both the TRACK, which is the test for respiratory and asthma control in kids, which is basically for kids under age 5 that go on a retrospective 4-week 5-question survey, and then the Composite Asthma Severity Index, which again has 5 domains. So you may be familiar with any or all of these, but I think in our clinic in Seattle, we typically use just the ACT, and on rare occasions the track for small children. What about exhaled nitric oxide? Many of you are probably familiar with this, and some may be wondering why this isn't done on every patient in every visit, or at least as often as spirometry, because there are some very good asthma specialists who use this on every patient on almost every visit, and some very good asthma specialists who almost never use this. And the question is, who's wrong? Is it being overused or underused? And I'm not sure of the answer. I will share with you as we go what I do. But basically, nitric oxide is a chemical that is produced by eosinophilic inflammation, which is not supposed to be in the lungs. So normal people don't have ENO in their or nitric oxide in their lungs, and so you need a very careful machine, precision machine, to be able to measure this, because exhaled nitric oxide is made in gobs in the nose. So in order to measure it, the machine has to be able to not be contaminated by nasal air. So it's a little bit of a trick, but over the past 20 years, they've developed some really handy and convenient devices now. And in general, an elevated exhaled nitric oxide predicts response to inhaled corticosteroids. And it also provides, for example, if a patient has an elevated ENO, it can be tracked over time. And if you suspect poor adherence, it's a great way of sort of objectively supporting that, because it typically inhaled steroids make this number go down. And so if they're not using it, like say they use their inhaled beclomethasone once a week, the ENO will be unchanged from the previous 2 or 3 months. It's also elevated in many asthma phenotypes, but importantly not all, and that's probably why there's so much variation in its utilization by different specialists. It's actually not a very widely accepted way to rule in or rule out asthma, so it's not the same thing as a negative methacholine challenge if the ENO is negative. However, it's evidence that it reduces the likelihood of ongoing asthmatic inflammation if it's normal. Similarly, if it's elevated, it doesn't prove that somebody has asthma. It's just a good guide, and most of us, like I use it in patients with chronic cough or in patients with normal spirometry who are having significant symptoms. And I really am not sure, and it's like ranges, for example, 0 to 25 or so, and if you get a patient with 110 and they have symptoms suggestive of asthma, but their spirometry is unimpressive, this could be a very useful test and something I would follow regularly in that patient. There are other confounders. For example, it's typically lower in smokers and during acute bronchoconstriction. Well, how about putting it all together? Remember, we only have 15 minutes for the whole visit in this patient. I'm going to give you 5 minutes to obtain the history with those questions we talked about. 2 minutes for that physical, since, as I kind of implied, it's rarely the definitive, decisive findings for your impression, but still critical to perform. And then 0 minutes, at least in our clinic, for spirometry and or peak flow, and at least ACT in our clinic. And the ENO, I'd say we'd have to probably give another 3 or 4 minutes for that one if we decide to do it. But the point is that you can customize your clinics to have done these ahead of time. A patient that you know has asthma and that you're seeing for the first time in the past 6 months, for example. And so you have this data in front of you. You have the ACT, you have the spirometry, and then going in to do the history, you're in that much better, stronger a position. And then discussion of the plan and counseling gives you 8 minutes, which is the majority of the visit. Well, hopefully that may be a Pollyanna approach, but I think that it certainly reflects kind of the flow of at least data into my mind when I'm seeing an asthma patient in the office. And of course, the next 30 minutes or 30 minutes at some point is done with a physician or other care provider entering data into the electronic medical record system to obtain meaningful use brownie points. And no, I'm just kidding. Yes, it's kind of true that there's a lot of extra time there, but it's just an illustration of our current events lately. All right, so I finished early, or earlier than 45 minutes anyway, because I wanted to leave plenty of time for questions and still allow you to get to your busy activities for the rest of the day. So how about we see if Sally has any questions that have accumulated.
We have a comment and we have 2 questions so far. So if you have a question, please feel very free to go ahead and write that into your question box at this time. So here's the comment. It says, you're right on in noted open-ended questions are key. They get right to the root of the issue. Another way to make the most of your visit is to ask the patient how you can be helpful. You may not get the info you want, but you generally get the information of what the patient and family wants, more on the lines of shared decision-making. Does that sound like something that you could agree with, Dr. Tillis?
I could not agree more, and I will even go so far as to say it was oversight to leave out the chief complaint and for validating that chief complaint one-on-one with the patient. So yes, you want to know what they're expecting out of the visit and what you can do for them that day. The pulse of asthma could be influenced by that, but I focused mainly on directed questions but I should have included that, so I appreciate it.
Terrific. Okay, here's a question. What is the best finding for detecting hyperinflation on physical exam?
Great question, and I don't think there's any sort of objective, validated measurement of that, but I think another way of saying that is barrel-chested. So you think of the COPD patient, the pink puffer, where they're breathing at the high end of volume, where it's like they've taken half a deep breath, and they never exhale beyond that. And it's kind of subjective. It can be measured with the pulmonary function in the laboratory, but it's more of a subjective impression. You might look at them from the side without their clothing and get a sense for whether there's an expanded diameter. We often see that commented on by radiologists on chest X-rays, but it's an excellent question and not something, as you could probably tell, I've downplayed the kind of the probability that a physical exam finding is going to be the key finding for that visit in that 15-minute pulse.
Okay, here's our next question. It seems as if we're seeing a lot more of the extrathoracic obstruction in teens and young adults these days, dysfunctional vocal cords. Can you comment on a quick way to distinguish this in the office? If we do not have office spirometry, is it the only way to really get to this is to send for spirometry? I've seen it in young adults with comorbid asthma and GERD and anxiety these days.
That's a great question, and the only reason I left it out is because I thought this whole talk would be biased, because that's kind of my special interest is what we call inducible laryngeal obstruction or paradoxical vocal fold motion or vocal cord dysfunction. And so we see a lot of this, and one of the most common phenotypes, probably the most common phenotype that I see is an adolescent athlete who has exercise-induced breathlessness, usually, but not always, will localize obstruction to their upper airway. So if you ask them to point with one finger where the air seems to get stuck, it's typically right in the throat or upper sternum. And if they're able to recall whether there's inhalation or exhalation, it's almost always inhalation, although that can be a misleading finding or misleading answer because sometimes they just don't remember. It tends to be dramatic. it's usually pretty easy to distinguish it from exercise-induced asthma by history, because exercise-induced asthma typically requires 5 to 8 minutes of intense exercise before it even gets started, whereas the vocal cord dysfunction can happen within 30 seconds or 1 minute or 2 minutes. Similarly, without treatment, exercise-induced asthma takes at least 60 minutes or up to 60 minutes to resolve on its own. So patients are pretty uncomfortable for a while. Whereas with BCD, you probably hear, the patient saying, "Oh yeah, well, I use my inhaler and then I go back in the game, or I just come to the sideline and it calms down after 5 minutes, and then I go back in the game and I'm doing fine, but it might come back an hour later." Well, asthma doesn't do that typically, and vocal cord dysfunction does that frequently. So those are some hints. If you were trying to do a stereotype, for example, that the patient has to be a straight A patient, a straight A student, and probably overly anxious, and having some psychopathology, or parents that are just totally overbearing, etc. Or, we actually did a study. It had funding, actually from our friends at the American Academy of Allergy, to do a study where we brought in 20 normal competitive adolescent female athletes and did the same questions and the same exercise provocation and laryngoscopy on the patients that we've done with our BCD patients. And it turned out that when you compare them with randomly selected adolescent BCD patients, there's no difference in their grade point average, and there's no difference in their whether they have a history of either doctor-diagnosed asthma, or doctor-diagnosed anxiety, or depression. And so, by the way, of the select soccer players that had no asthma and no exercise limitation, their average grade point average was about 3.8. So I think we have to be careful about stereotypes. The anxiety or depression is absolutely a risk factor for vocal cord dysfunction in this age group, or actually any age group, but it's not necessarily required. And I think the intensity of exercise, especially in a developing female adolescent larynx, is at risk anyway. And so just the intensity is probably what's the most distinguishing feature. So I could go on and on, but I'm going to stop myself, since I don't want to take up all the time with this one question. But I do appreciate it, and it is a very commonly encountered problem.
Okay, in the school setting, in the school nurse's office, do you think that peak flow is a useful tool?
That's a good question. I mean, it certainly is a useful tool in selected patients. I'm not sure how helpful it would be for a school nurse to have one laying around, and then some random student comes in with dyspnea, and they're going to try to make sense out of that, because it's not it's mainly meant at home in patients that have had a provider sort of guide them into what their either personal best or their usual number is when they're under control. In that patient, where they've been sent in the nurse's office, there's an albuterol inhaler and a peak flow meter, along with an action plan that includes peak flow parameters, then it could be useful. But we're asking a lot of school nurses these days, and so I'm definitely sensitive to asking too much of them, especially if they're expected to cover multiple schools, for example. But it certainly may have practical value as long as it has been either prescribed or recommended by the provider that's taking care of them.
Okay. Next question is, where does device training fall within your 15-minute visit?
That's the counseling, okay? That's why I allowed 8 minutes. The majority of 15 minutes was not in obtaining a history. And remember, this was taking a pulse of asthma, although I suppose one could argue that observing inhaler technique is part of taking a pulse. But I think, yeah, so after all the data collection, including the exam and tests and whatnot, then it's, ask myself, how are things going, and is there anything else necessary either change in management or rethinking the device. And to be honest, with all of the diversification and differentiation of different products these days, there's many different techniques these days for inhaled asthma medication. So I wouldn't. So there's meter dose inhalers, which is one thing, and then trying to decide whether to use a spacer. And then there's a whole bunch of new patented technologies that are used for either dry powdered inhaled devices, etc. So absolutely need to do that if you're starting something new, or if there's any problems with the device they're using, or if you have any concern about the amount of medicine being consumed and the effectiveness that it's having. It certainly, if it's not working, like for example, if they continue to have symptoms despite reasonable treatment after training them the first time, before assuming they have vocal cord dysfunction or something like that, I would absolutely recommend observing their device technique.
Okay, great. Do you find physicians are able to distinguish when asthma is no longer correct and they have COPD?
Well, that's a great question, and it's also sort of a trendy theme these days. And they call it, hopefully you guys have heard of ACOS or ACOS, asthma COPD overlap syndrome, and it's an area which, especially with the baby boomer population, there's going to be a lot more COPD coming to our practices, and as I've already talked about, there's a lot more asthma now than there was 50 years ago. There are important differences still, but we're hoping in the American College of Allergy, even though allergy and asthma is in our name, COPD is not, we're making sure that our programming includes the overlap syndrome and specific comments on COPD, and even medications approved for COPD but not asthma, just so people are familiar with these approaches. Because sometimes it's hard to tell the difference. Sometimes it doesn't matter because the treatment's the same. It depends on the patient. And then sometimes they're completely different. For example, the 25-year-old with hay fever who needs albuterol, several times a week for 3 weeks during the pollen season is quite different than the patient who's smoked for 50 years, is now 60 years old and is oxygen dependent, and they have different medications, the whole different ball game. So it is important to understand the differences, but realize that there's this middle area that's becoming much more overlapped than we thought 20 years ago.
Well, that's great information. The next person wants to know, what age do you recommend for the ACT? Could it be used in children? And what's your recommendation for an asthma screening tool?
Yeah, so the ACT, I didn't go into it. There's actually two tools, an adult and a child one. And our group has the 6 and above is, I think it's 12 and above for the adult one. And then there's one, I think 5 to 12 that is administered. And then for under 5, we usually use the track survey, which is that other instrument. So these are, you can just do an internet search for any of these names and get the actual, I call them instruments, but they're actually, one-sided, one piece of paper that you can print out and see exactly what they're capturing, and they have the different age groups for each one. But yeah, you can use, there's 2 separate ones that have been validated for ACT.
Okay, how do we explain to providers that a patient still has persistent asthma when on a controller? Many of our providers change the asthma classification to intermittent. Any talking points would be great.
Yeah, it's really difficult, especially when I introduce that topic of future risk. So if they have required oral corticosteroids 2 or 3 times in the past 6 months, I don't care if they have 100% FEV1 and no symptoms, they should be on an inhaled corticosteroid and they have persistent asthma. And I think that's an education thing, and many doctors and even asthma specialists are sometimes guilty of that, of just sort of not going in, analyzing future risk as carefully as possible. But on the other hand, we're also being much more flexible about if the FEV1's a little low, is that a racial thing? In other words, normal for their race, and we just don't have the right ethnicity correction for spirometry, for example, or is that, and they don't want any treatment? Is that okay? I mean, because the patient's desires are so important. And so I think just impressing what we do know, which is number one, that the inhaled corticosteroid class is generally very safe, especially in low doses. And if the history and either the history of symptoms, spirometry, or previous sort of retrospective survey of how dramatic their events have been warranted, then at least that you need to go on record with that primary doctor, with that primary provider, and with that parent or that patient, that your strong recommendation is they be on this medication. If they decline, they decline, and I'm getting more used to that because that's the era we're in. I mean, if someone's really opposed to corticosteroids, I respect that, even though I try to undo it, and they are forced to sort of, in a friendly way, tell me no again the next time. And so I try to wear them down. And then if I think they're definitely would be, if we have good evidence that they're going to be safer taking something than not taking it, then I share that with them. But I'm also flexible about choices to do otherwise.
Okay, great. Well, our next listener said, I just did a PFT on a patient today, 32 years old, and her ratio is 59 before and 70 after. Due to no insurance, she has been managing her asthma symptoms with borrowed albuterols. Do you feel she has remodeled her airways, or will better management help improve her outcome?
Well, that's a great idea. Well, she's certainly not irreversible. Okay. 50 to 70 is almost, let's see, so that's more than 50% reversibility, or 59 to 70, and it's a tremendous reversibility. So that if there is any remodeling, it's not below the normal range permanently. So in other words, we wouldn't really know the answer to that unless we put the patient on prednisone for a couple of weeks and then repeated the spirometry at their best baseline. But because albuterol isn't necessarily the way to isn't necessarily going to reverse them fully every time, especially if they're not doing well. So I would emphasize to that patient the fact that it reverses means it's still salvageable, and that that more information about their history and potentially testing would be helpful to help direct the right therapy at that point. But yeah, that's concerning. Most of us that would be that low would be living a limited life compared to walking around at 85%.
Okay, we're going to do two more questions. The first one is, how frequent do you do spirometry, and do you see a role for home spirometry?
Really good question. I think the sort of national guidelines require or suggest that you do spirometry in every new patient suspected to have asthma, and then periodically thereafter, whether that be once a year or even less than that. In our clinic, we typically do it at any visit at their at least once a year, and then any visit where their asthma may still be active. So if it's once every 6 months, or even once every 3 months if they're still symptomatic. So it depends on the patient, but it doesn't have to be every visit in our practice. Though I don't think people are faulted for doing it. I just make sure that it's not that if other people are making the decision whether to do spirometry or not. For example, a medical assistant checking a patient in, that they make sure the asthma is still active. If the asthma is gone and they haven't used an inhaler in 3 years, there's no reason to do spirometry, especially if they're not limited and not complaining of anything that day that relates to asthma. So we're sensitive to over testing, but by the same time, or at the same time, it's okay to do it more than once a year.
Okay, and our last question is, do you recommend spacers and aero chambers for the MDI inhalers?
That's also great. These are excellent questions, by the way, so I appreciate everybody being so thoughtful. The spacer used to be mandatory with the CFC devices. With the HFA inhalers, none of them were approved with a spacer device in the clinical studies typically. So I can't say that they're mandatory, although in my experience, I'd be more inclined to use one in any child because I think it helps with their technique, and in any adult who is on an inhaled steroid typically, because I think regardless of what the companies tell you that make these things, I mean that these steroids are so potent these days, especially when you get higher than the low doses, that there's a lot of corticosteroid going through the pharynx and the larynx. So rinsing it out is obviously important, but if you can put a spacer between the mouth and the device, then the amount of medication that would otherwise be deposited in the first thing it hits will be deposited on the spacer rather than inside your mouth and in your throat. That's largely anecdotal, so I don't want to say that it's inappropriate not to use a spacer. In an adult, but also let's be clear, in an adult who's been properly trained with a metered-dose inhaler, for example, albuterol, with deep inhalation and breath holding at the end of inhalation, there is no difference between the effectiveness of that dose and an effectiveness of a dose using a spacer, or a dose using a nebulizer for that matter, in a patient that's at least able to do the technique properly. So it isn't necessarily as important to get the medication into the lungs as it is to protect the upper airway from side effects.
Well, thank you so much, Dr. Tillis. We so appreciate all the information that you've shared today, and I'd like to thank our listeners for listening today. Allergy and Asthma Network is offering a new resource to you. We have a 3 to 5 minute video post of our popular Ask the Allergist series. On our website, under News and Views, click on Ask the Allergist. This month's post features Dr. Julie Wang speaking on evaluating the potential of oral immunotherapy and the peanut patch. And please join us next month for our April webinar on the creation and implementation of SAMPRO, a school-based asthma management program. You can register for this webinar on our website at allergyasthmanetwork.org. Look for education on the horizontal navigational bar near the top of the page and scroll to webinars. You can also view our archived webinars on this page on our website. Visit our website for quality guidelines-based resources on allergy and asthma. Also, access important medical information on allergies and asthma from our partners, the American College of Allergy, Asthma, and Immunology, at allergyandasthmarelief.org. Thank you again for joining us, and we look forward to having you register to be with us next time on Advances in Allergy and Asthma. This is Sally Schessler for the staff at Allergy and Asthma Network. We wish you a great and healthy day as we work to breathe better together.